do apologize. Apparently we didn't have audio there for a few minutes. Looks like we have it back now. We will get through these technical difficulties. I am sorry. So just to go back just a little bit, we won't go back too far, but just to reiterate, some of the effects of use are going to be that relaxation, that altered state of consciousness. It can impair coordination and judgment. These are the things that we typically see when someone is what you would call high. Tolerance does get stronger over regular use, but what we have found is the withdrawal symptoms are actually nowhere near as severe as other drugs such as alcohol or opioids. Some of the withdrawal symptoms we see may be irritability, restlessness, nausea, stuff like that. But it is typically not as bad as these other drugs. So that is just something to keep in mind. All right, so what are some of the cannabinoid receptors? Well, there are two main receptors in the body that are activated with marijuana use. The first one is the CB1, and this receptor is located primarily in the central nervous system. Activation of these receptors typically results in effects of the sensation of pleasure, of memory, of thought, concentration, sensory and time perception, and coordination. Again, this is going to be the part where you see someone referred to as getting stoned or getting high. And then we move on to the CB2 receptors. These are located primarily in the peripheral tissues and in the immune cells. Activation of these receptors can lead to immunosuppression, anti-inflammatory effects, and reduced sensations of pain. So this is the part where we typically see people using THC for medicinal purposes, or even CBD, which CBD is actually part of the flower. These CB1 and CB2 are receptors, so they're totally different things, but the CBD is going to have more of an effect on that CB2 receptor when we're looking at things like medicinal use. All right, so what is the legal status of marijuana in the US? So marijuana is a Schedule I controlled substance, and its possession and its use is still illegal under federal law. A number of states, including the District of Columbia, do have laws permitting the use of marijuana for medical treatment. And a few of these states have laws that do permit recreational use of marijuana. So it's kind of all over the board. None of the states agree. Everybody's doing it a little different. But many of these laws do not specify for what conditions the drug can actually be used for. They only require that a licensed physician certifies that it's medically necessary. So, we may see someone go in and get medical marijuana for back pain, or we can see it for glaucoma, or we can see it for anxiety or sleep issues. There's nothing that really regulates when it should be used or what it can be used for. And in the few states that do regulate somewhat, obviously, again, with state to state, it's going to be very, very different. None of the states seem to agree on how it should be best used. In addition to this, many of the laws don't specify that an ongoing doctor-patient relationship is actually required. There are states where you can go to a doctor once, get the card, tell them your back hurts, and you're good to go. You never have to see the doctor again. That also can cause a problem and is something that is looked at by underwriting. When it is a medicinal purpose, they are going to look at that ongoing relationship with the prescribing physician. The administered drug can be used in several oral forms, or it can be inhaled by smoking. This also could vary state to state. Some states we see, or in some cases, I should say, sometimes we see edibles, sometimes we see oils, sometimes we see lotions. There's all sorts of different forms that this comes in. But at the end of the day, what it all kind of boils down to right now is that in many, many cases, these laws have just resulted in de facto legalization of recreational use because there's just not a lot of ongoing monitoring with the medicinal use. All right, so for medical purposes, common medical uses that we see with THC and marijuana, the medical use of the marijuana typically falls into 5 major treatment areas. One of the first ones is going to be severe nausea and vomiting that is typically associated with cancer, chemotherapy, and some other causes. That would be one of the first and foremost that we see it. The next is going to be weight loss, whether involuntary appetite loss, sometimes again due to cancer or HIV or other illnesses. You hear people joking about marijuana giving you the munchies. Well, it's kind of true. And that is why it is oftentimes used for involuntary weight loss and appetite issues. It can also be used in the spasticity that's secondary to a lot of neurological diseases such as MS or Parkinson's, spinal cord injuries. This can be beneficial there. It is also used in pain syndromes, whether that's neuropathy, migraines, musculoskeletal disorders, all sorts of different purposes there. And then obviously we've heard over the years that it is used oftentimes for glaucoma to release that pressure. So those are the most common uses that it will be broken down for. What we have found is that the evidence that supports the treatment with marijuana for these conditions is actually quite limited. Primarily because clinical research has been hampered due to the Schedule I status of the drug. Studies on the safety of the drug have also been limited and generally been confined to very short durations. In the short term, these studies have not shown a high risk of major adverse side effects. So typically, any of these side effects that may be involved are going to be less than or worth it as compared to what it's being used for. It's just something to keep in mind. There's still a lot of testing to be done, but as of right now, it appears to be worth the risk for the purposes it is currently being used for in the medical field. Now, as for the adverse health effects, we have started digging into some of those. And what we have found is that while it's considered one of the safer and more common drugs, and I use the word safe very lightly, there's no such thing as a safe drug, but it is obviously one of the more common drugs in the United States. There are still a number of adverse effects that may occur with marijuana use. First off, inhalation of the drug is associated with an increased risk of lung cancer. Marijuana smoke is usually more deeply inhaled. It is held longer in the lungs than tobacco smoke, and it actually contains 50 to 70% more of the cancer-causing chemicals than tobacco does. A lot of people don't realize that. They think because it's natural, it's a plant, it's safer. That's not necessarily true. In terms of lung cancer risk, the use of 1 joint per day is roughly equivalent to 1 pack of cigarettes per day. And the inhalation of that marijuana smoke is also associated with an increased risk of bronchitis and asthma, but interestingly enough, not emphysema. I won't dig into that. I think that's a webinar for another day. The other thing we have found is that the risk of psychiatric and social disorders is significantly increased. The risk for development of psychosis is increased, and there's an increased risk for the development of schizophrenia, possibly bipolar disorder, and depression in predisposed individuals. And in addition to all of that, the use of marijuana is associated with higher levels of anxiety, impaired memory, poor concentration, and long-term learning disabilities. You may hear about people getting paranoid. Well, that's the anxiety part of this, or the impaired memory. It really has some long-term effects on short-term memory. So that's just a little something to keep in mind there. Marijuana does also have a variety of effects on the cardiovascular system. It's associated with vasodilation, hypertension, tachycardia, different arrhythmias. Individuals that know they have CAD or coronary artery disease, they do have a greater chance of a poor outcome if they smoke marijuana. There is also, they have found, an increased mortality risk even with light use after a myocardial infarction or a heart attack. So definitely after a heart attack, they recommend you do not light that joint. It is definitely going to increase your risk of a negative outcome there. A few other just little side note pieces they've come up with is that this drug is associated with significant bone loss. So there is an increased risk for osteoporosis. Man, I can't speak today. Use of the drugs also associated with risk-taking behavior and other drug use and just poor judgment in general. But the use of opioids with marijuana is especially problematic. That is something that if they are seeing that combination in medical records or in the history is likely to have a negative outcome. All right, so what are some of the things that we have to look at from an underwriting perspective? So some of our typical requirements are going to be drug screening via the insurance labs. That is something that, 20 years ago, a lot of companies started testing for THC, and if they saw it, it was an instant decline. And then it became a little bit more lenient that, well, if we see it and you admitted it, then we'll talk about it some more. Now, a lot of companies don't even test for it. They just ask the question and it's no longer part of their insurance labs. But they can always go back and have that run if they feel a need to, if they have any reason to feel like that is something they want to see on the test, they can still do it, but it's not as automatic as it used to be. One of the other things that they are always going to ask for is going to be an APS. This is one to see if there's an ongoing use, heavy use or abuse type situation, if there's any negative comments from the physician. They are also going to look at any other lifestyle behaviors that may come into play. They're going to look at mental health. They're looking for comorbidities that are maybe going to make this drug use more problematic than it would be for another person. They may see a history of psychosis, and while the person maybe was using a minimal amount of marijuana and one client would have been approved, somebody with all of a sudden psychosis in their APS, that's going to be someone that's likely to be a decline. So they're looking for comorbidities there and for any kind of negative issues with that usage history. They're going to be looking at the MBR. That's not just for DUI purposes. They want to see if there's any history of reckless driving, speeding, just risky behaviors in general. Obviously, if there is a driving under the influence charge out there, that will be looked at as well. But yes, they want to see good decision making when it comes to this use and you having a vehicle that you drive. Drug use questionnaire. This one we see quite often, and I know a lot of times agents get very frustrated. They don't want to go back to their client for that because it feels like their client's being accused of something, or they're being judged. And honestly, that is not the case. I implore you, when you have a drug use questionnaire that comes up, it's oftentimes to help the client tell a bigger story. We may have somebody who mentioned to their doctor that, I smoked a joint while I was at so-and-so's bachelor party 2 years ago, and the doctor notes marijuana in the file with absolutely no details. They do not tell the whole story. They just mark marijuana in the APS, and now it looks like your client is potentially using marijuana every day. They don't know. They have no idea. The drug use questionnaire gives the client the opportunity to really tell the story of how often it's used, if it's on a regular basis. If it is on a regular basis, is it for a medical purpose? If it's not necessarily medically prescribed, but you're still using it for a medical purpose, like it helps me sleep at night, it allows the client to tell that story without being judged based on one little item that may have shown up, like I said, kind of in like medical records. Um, it all it also gives them a chance to tell how often they're using, how long they've been using, the dosages. I mean, all these things that can come into play that the doctor's report is not necessarily going to convey. And then last but not least, inspection reports. And this is something that honestly we very rarely see anymore. We used to see those ordered quite a bit many years ago, but it's very rare occasion that we see those and have those interviews done, because now we can just use the drug use questionnaires. All right, so what are some of our most likely outcomes going to be? We will unfortunately see an automatic decline if we find a young user who's been using prior to the age of 18. The little brains are still developing at 18. So anyone under that age that comes in with a positive THC level or even admits to it, that is going to be automatic decline, unfortunately. Another time that we typically, and I say typically because there are variations, but typically we'll see an automatic decline is going to be if it's a synthetic cannabis that has been altered by humans. Typically we'll see these named as like K2, Delta 8, or Spice, or some other weird trendy name that's popular at the moment. There are cannabis shops in states where it's still illegal that will sell these synthetic cannabis products. And they have been found multiple times to not be safe, to be less safe than traditional marijuana with THC. So a lot of carriers, if it is known that it is a synthetic cannabis they are using, will automatically decline that. Again, I say most. Every now and then we see some get through. So when in doubt, I would shop it out. But moving on to some of the more favorable outcomes, we have found that with recreational use only of the plant, nothing, we're not talking about oils or anything like that here, just smoking the actual flower, that rating is typically going to depend on the amount of use, and it is going to vary by carrier, and it is going to vary greatly. This is one I always recommend that we shop because it changes all the time. And we see a huge variety of ratings on this. So what they're typically going to be looking for with recreational use only is that there is no ongoing depression, anxiety, attention deficit disorder, none of those other psychiatric conditions, like psychosis, schizophrenia, bipolar, all those. They do not want to see any kind of history of alcohol or substance abuse. Even suspicious, notes in an APS can end up with a negative outcome. And so those are definitely things they're looking for. Definitely no history of chronic opioid use or abuse for pain. Opioids combined with marijuana, big red flag. That's a big no-no. They don't want to see that there's any suspicion of you being completely dependent on marijuana. If that's, something that they see in the medical records, everything else could be perfect. But if the records show that there's a true dependence issue there, that will be frowned upon. And then obviously no adverse side effects. You got someone who says they were smoking marijuana and then had a seizure and ended up in the ER. I mean, these are the kind of things that is going to play out negatively, unfortunately. Okay, and then some of the possible outcomes that we will see with medicinal use only, with a prescription and physician supervision. This is where you're going to see probably your most favorable outcomes. The they're typically going to underwrite this based on the underlying condition, not the marijuana use itself. So if you are being treated for, let's say, MS, and medical marijuana is part of that treatment regimen, then you're going to be underwritten for the MS itself. And the marijuana use is pretty much, I don't want to say ignored, because it's not fully ignored, but it is not going to be scrutinized the way recreational use would be. And then what we have also found is that if you're using medicinal marijuana, let's go back to that example maybe for sleep, and you were prescribed by a physician in a state that allows that, and you've never been back to see any physician for the next 2 years. You just got that medical card, you went and got your marijuana, now you're using it every night for sleep. That's actually going to be more than likely treated kind of as recreational use. Yes, it was prescribed, but there's no ongoing physician care or supervision. And so a lot of times they will treat it as recreational use and then rate for the medical condition that is in question. Okay. And with that, we will run into just a few of the other little things that we happen to know about this drug is that typically when we see that someone is using marijuana, but it's via vaping or THC oils, and they are not necessarily using the flower itself, that is usually going to be rated as e-cigarettes. And a lot of times with those, that is going to be a tobacco rate. So knowing how your client is using, what they're using, that will definitely be key in obtaining offers in advance if we need to. Any kind of polydrug use, marijuana combined with other drugs, is typically going to be a decline. And DUI or driving issues, obviously those are going to be individual consideration. It's going to depend on the client's age. It's going to depend on the rest of their history. All sorts of factors that will be taken into consideration there. But if we have an ongoing marijuana user with a recent DUI, we're probably going to see that get declined. However, if this was a DUI back in their 20s and now they're in their 40s and they're using it for back pain, it's completely separate incidents and kind of a moot point. Those are probably going to go through just fine. So again, individual consideration. There's a lot of big picture items that are going to be looked at there. Smoker versus non-smoker status. This is going to depend on the use method and how often it's used. We have seen people that smoke the actual flower that can still get non-smoker rates with certain companies as long as they don't do it over 2 times a week or 3 times a week or 4 times a month. I mean, they're all over the board. So this is something, again, I always suggest we shop because every carrier is very, very different and they are changing quite frequently. And then we'll see things like edibles, or oils, like I said, or pills that have oils in them, or sometimes it can be lotions that you rub on the skin. These we will more often than not see the non-smoker rates, obviously. And again, they're going to look at the dosage amount and how frequent it's being used, but those will get us away from that smoker rate. And again, having a physician involved is going to help with a more favorable consideration on this. If there's no doctor that's been monitoring your use since you got the card 2 years ago, I'm not going to say it's frowned upon, but you definitely get some bonus points for having a physician that's still involved in this treatment. All right, so let's jump into a couple cases we've seen here recently, just as examples of what we've been running into. So we had a young lady here recently, mid-30s, non-smoker. She works at a vape shop, and it is part of a medical marijuana clinic. Now, the proposed insured, she sells the vape products. She does not work on the marijuana side. She is on the vape side of this little shop. She does not use the products, and she has no medical history. So typically, an agent may look at this and think, well, she's perfectly healthy. There's no reason we can't get her at preferred or preferred plus. Unfortunately, we ran into a decline on this. And when we went to shop this out with other carriers, we received declines from every single company that I could think to go to. This is not necessarily due to anything that she's done wrong, but federal law does not allow still for marijuana to be considered legal. And so there's a lot of banking issues, there's AML concerns. It's a very high risk industry in the sense that they are cash only typically, which means higher robberies, higher theft, breaking and entering, all these kinds of things. So you're looking at a high risk industry that also has banking concerns and federal laws in place, and therefore we were not able to find any carrier who was willing to insure this young lady with this employment, even though she's not using. Case number 2, we had a male in his late 30s. He was smoking marijuana about 3 times a week. Most of the carriers came back and they were in the table 2 to 4 range. We had, I believe, one standard non-smoker, but the most of them came back table 2, table 4, smoker or non-smoker, just depending on the company. That again was kind of all over the board, and so definitely something that I would recommend shopping, as I stated before. And then this was not a specific case. I did not give any specific client details because there is no reason to. I get this question at least once a week. Someone will call and say, hey, I've got a guy, he smokes marijuana every day. What can we get him? This is going to be anything from standard non-tobacco all the way up to a decline. I've seen standard table 4 tobacco, non-tobacco. It just goes all over the place. This is one, again, I would definitely say that we need to shop. This is going to vary for multiple reasons. They're going to look at the client's age. Someone who's 22 and just getting started and still young enough that a whole lot of risky behavior could take place is probably going to be looked at very differently than a 65-year-old who's doing it every day to go to sleep at night. So the story matters. We need to paint the picture. We need to be able to really tell them, what they're doing, why they're doing it, how it's helping them. They're something as simple as their employment, their career choice could come into play. Someone who sits at a desk all day might be a little bit safer for them to smoke weed every day than it is compared to someone who's on a tractor hauling glasses, or I don't know, something huge and dangerous. I mean, it's all going to be looked at and taken into consideration and on a very individual basis. So just something to keep in mind there. Always want to paint the picture and get the whole story out. All right, and so how can IAMS help you with these cases going forward? Make sure you reach out to your sales marketer, your sales guy, or myself. We do have fact finders out on our website. We have a very general health screening questionnaire that covers a little bit of everything: avocations, criminal history, personal health, family health, all of those things. This is a good starting point when you're meeting with a client for the very first time and just need to get a broad idea of their history. And then on top of that, we do also have our NAILBA guide out on the website. This is going to be more ailment specific. There are questionnaires out there for drug use, MS, strokes, heart attacks, diabetes, pretty much anything you can think of. The most commonly seen issues in underwriting, those questionnaires are out there, and we can send those to you, or you can get them on the website. You can pre-screen these with me. You can shoot me an email at andrea@iamsinc.com. You can call me. You can send a carrier pigeon, however you would like. We can discuss that insurance history and kind of narrow down which carrier is going to be the best option. Again, your sales director is also there if I'm not available, and they can get that information over to me as well. But yeah, those health questionnaires where appropriate, those can save a lot of time on the front end, and that way we're not trying to move cases around after we've gotten a rating or a decline or whatnot. We like to find the right carrier up front, so you're not putting your client through a whole bunch of extra underwriting just to have to move companies. And with that, please follow and like us. We are on Facebook and LinkedIn, and we certainly appreciate you being here today. And if you have any questions, please feel free to reach out. Have a great afternoon. Thanks so much.